Alrighty, so now we're going to start chapter 13, which is our respiratory system. Whoops, hit the wrong button there. Let's talk about some organs of our respiratory system. First of all, our respiratory system is divided into upper and lower tracts. The upper tract includes the nose and the pharynx, or our throat. The lower respiratory tract includes the larynx, which is where our vocal cords are, the lower throat area, the trachea, the bronchi, bronchioles, and the lungs. So here you can see the upper respiratory tract, including our nasal cavity. The nostrils themselves are called external nares. The nasal concha, which you may recall from your skeletal bones, those are those little kind of extra pieces of bone that are covered in a mucous membrane to allow for turbulence with the air coming in. This is going to warm and humidify as well as filter the air that comes in. The nasal septum, dividing the nasal cavity into right and left sides. That nasal epithelium with those special chemoreceptors we talked about back in chapter 8. The nasopharynx is this top area of the throat. This is going to exchange air with the nasal cavity. This is also going to help receive any dust packets that may get trapped in the nose. It's going to be sent to the mouth and allowed to accumulate in the saliva, dissolve in the saliva. This is also for equalization of air pressure within that auditory tube. You can see this little hole here. That's actually the eustachian tube or auditory tube coming from the ears. The oropharynx is the basically the back of the mouth, or the back of the throat, so to speak. This is the middle part of the pharynx opening into the mouth. This contains the palatine and lingual tonsils to help with immune reactions for any incoming pathogens. And then the laryngopharynx, which is the most inferior part of the pharynx. This is the lower part going connecting to the esophagus and larynx. Here you can also see the, where'd my mouse go? There it is. The larynx, a little piece of cartilage called the thyroid cartilage, which is also your Adam's apple. You can kind of palpate that and feel that on yourself. There's little cricoid cartilage in there, as well as the thyroid gland, which is a soft tissue glandular endocrine structure in your throat. The lower respiratory tract, including the larynx, as I mentioned, that thyroid cartilage that you can feel, that's that Adam's apple. The epiglottis is a little kind of flap of cartilage that covers the airway when you swallow. This is kind of what moves back and forth around your vocal cords. You can here see the trachea, which then branches into the primary, secondary, and tertiary bronchioles, which we'll get into a little bit later. Those bronchioles branch off into the alveoli, which is the exchange surface of the lungs. If you recall, the right and left lung are surrounded by a serous membrane called the pleural membranes. The pleural membranes enclose the pleural cavities. The pleural cavities is the space between the lung and the pleural membrane that's filled with special pleural fluid, which allows for reduction of friction. The lobes themselves are divided into lobes. You have the superior lobe on both right and left lungs. On the right lung only, you have a middle lobe, and you have an inferior lobe on your right and left. Notice the differences between the right and the left. There's a small notch taken out of the left lung, and that's called the cardiac notch because what sits right here in the mediastinum but your heart. And as we know from our circulatory system, the heart is thicker on that left side because of that left ventricle that has to provide lots of force for generation of contractions, and so that's where you see that cardiac notch taken out of the left lung. The base of the lungs sits on top of the diaphragm. The various lobes of the lungs are divided by what's called fissures. There's a horizontal fissure on your right lung, and then both your right and left lung have what's called an oblique fissure. Note the difference in the lobes, though. The oblique fissure on your left lobe, or left lung, I should say, is dividing the superior from inferior. On your right lobe, it's dividing your middle from inferior. So let's talk in more depth about that upper respiratory tract. First, you have your nose, which is covered in the nasal epithelium, your pharynx, or the throat. Ultimately, the whole function of your upper respiratory tract is to warm, filter, and humidify the air coming in. You don't want the air to come in to be cold, you don't want it to be dry, and you don't want it to be full of debris. So The whole purpose of your upper respiratory tract is to warm, humidify, and filter. It also helps to detect the smell that's in the air. It's also going to expel mucus from the respiratory tract. The lower respiratory tract begins with the larynx. That's the entrance to the trachea. It houses the epiglottis, which is that little flap, which closes during swallowing so that food does not get into the larynx and then the trachea. The glottis is the space between the vocal cords, and the vocal cords themselves within the larynx are special folds of tissue which vibrate as air moves past them to help create sound. Air passes through these vocal cords. The vocal cords are going to vibrate, changing the flow of air through the passage, ultimately producing the various pitches that you hear as your voice. Then there's the bronchial tree, which is a series of branching tubes that direct air through the lung tissue. Begins with the trachea, branches to the bronchi, and then eventually the bronchioles. Then you get to the lungs themselves, which is where all of the exchange surface is going to be sitting for the exchange of gases with our circulatory system. The lungs themselves are enclosed in that pleural cavity, which is encompassed by the pleural membrane. The pleural membrane forms what's called the pleural fluid, which helps the lungs adhere to the thoracic wall. This also is going to allow movement of the thoracic wall to bring air in and to allow the lungs to push the air out. The lungs extend from the diaphragm to just above the clavicles, and they lie against the ribs. The broad bottom area is called the base, that sits on top of the diaphragm, and then the narrow top portion is the apex, kind of the reverse of the way the heart was positioned. The left lung is about 10% smaller than the right lung because the heart occupies some of that left side space. The left side only has 2 lobes, as I pointed out. The right side has 3 lobes. Each lobe has its own secondary bronchus for delivering air. The alveoli are the tiny air sacs within the lung that attach to what's called the alveolar ducts. This is the site of gas exchange between the lungs and the blood. The pulmonary, arterial, and venule form the capillary networks around the alveoli. The diffusion of respiratory gases takes place at the junction of the alveolar membrane and the capillary wall. So let's take a closer look at this. You can see up here in this picture of the lung, you can see the trachea branching into the primary, secondary, tertiary bronchioles, and then eventually getting so far down we get to what's called a terminal bronchiole. The terminal bronchioles branch into the respiratory bronchioles. The respiratory bronchioles branch into what's called the alveolar ducts, which are kind of like these little stems. And then you get to these alveolar sacs. This entire structure is called the alveoli, and the alveolar sacs are these little bubbles within the alveoli. These are very microscopic pathways. You can see here on this alveoli how many blood vessels are innervating it. It is very infiltrated with oxygenated and deoxygenated blood. Of course, this artery is taking the blood away from the lungs and back to the heart. This vein here is bringing blood from the heart to become oxygenated. So let's talk about what's going on. Whoops. I'm going backwards. Sorry about that. I hit the wrong arrow. There we go. There's over 300 million alveoli in the lungs. It's a very large surface area, up to, I think the statistic is something like 3 football fields worth of exchange surface for gas exchange. There's something called surfactant that's secreted here. It's kind of like a fatty lipoprotein mixture. It's ultimately going to decrease the surface tension in the alveoli, making the lung tissue very flexible, allowing it to expand when it's filled with air. These alveoli are also interspersed with macrophages. Macrophages are those little Pac-Man-like cells which help remove dust and debris from the incoming air. So how is gas exchange accomplished? Ultimately, you have what's called pulmonary ventilation, which is breathing, bringing the air in, exhaling the air out. And then there's external respiration. External respiration is the gas exchange between the alveoli and the blood within the pulmonary capillaries. This is exchanging with the external environment, which is why it's called external respiration. The oxygen diffuses from the alveoli to the blood. Carbon dioxide diffuses from the blood to the alveoli. That's external respiration. Then you have internal respiration, which is the gas exchange between tissue cells and the blood in the systemic capillaries. This is exchanging within the internal environment. So the oxygen is going to go from the blood to the tissues. Carbon dioxide is going to go into the blood from the tissues. So here you can see the gas exchange surface, this overall structure of the alveoli. You can see how close these blood vessels come to that exchange surface, to that alveolar membrane. It's just a very, very thin layer there that these gases will exchange across. There are special alveolar cells which secrete that sticky surfactant substance. There's also a little bit of interstitial space filled with interstitial fluid. There's alveolar cells, which are basically simple squamous cells where the gas is going to exchange through them. The alveolar fluid fills this area covered with surfactant. You have a macrophage there ready to gobble up any extra particles, and then the red blood cell within the capillary that's pointed out again, the exchange surface right here. If we look at this exchange surface, we're just kind of zooming into this one right here. You can see where the oxygen is going from the alveoli into the red blood cell, and then from the red blood cell, or from the systemic circulation, or pulmonary circulation I should say, you're losing the carbon dioxide into the alveoli, and that's when you breathe out. Pulmonary ventilation is when the air moves from areas of high pressure to areas of low pressure. So in order to do this, the lungs have to create an area of low pressure. The lungs and the chest wall are very elastic, and they oppose each other, so they're going to act like a spring. There's special adhesion from negative pressure of the pleural space, as well as suction properties of that pleural fluid. Boyle's law is going to play a role here. Basically what this says is as the pressure decreases, the volume is going to increase, and vice versa, as long as there's a constant temperature. So let's just look at this briefly. This is that Boyle's law. Try to my hand at cursive there. So let's say this is a lung, and let's fill our lung with lots and lots. Whoops, it's supposed to be dots, not lines, sorry. Lots and lots of air, in this case lines and air. These dots are supposed to be air molecules. So let's say there are 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, let's say 15 air molecules in this space. Well, if we were to put 15 air molecules in this space, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. Whoops, it's kind of messed up, but just imagine there's 15 there. This has a higher pressure. Higher, again, sorry for my handwriting, higher P for higher pressure. This one is going to have a lower pressure because it has a higher volume. So it's this inverse relationship between pressure and volume. The larger the area, the lower the pressure. The smaller the area or volume, the higher the pressure. So let's refer this back to lungs in this case, and the process of inhalation. When you breathe in, the diaphragm and external intercostals contract, which is going to expand the thoracic cavity and the lungs. This is an active process. It uses energy because the muscles are contracting. So following Boyle's law, making an increased volume is going to decrease the pressure within the alveoli. This pressure is going to be lower than atmospheric pressure, the pressure of the world around us. So the air is going to follow that pressure gradient. It's going to go down the pressure gradient. We're going to get air moving from where it's in high pressure to areas of low pressure. In this case, because our lungs have expanded, there's lower pressure within our lungs than the external environment, so air is going to now come into the lungs. Exhalation is a passive process. Those respiratory muscles relax. The thoracic cavity is brought back to its original volume. That decreased volume is going to increase the pressure. It's going to be higher than atmospheric pressure, which is going to force the air out of the lungs. Again, it's a passive process. It does not require any energy. There's also forced exhalation, which actually is an active process. This would be like when you're playing a woodwind or brass instrument. This would be when you're trying to blow out, not when you're just sitting there quietly reading and breathing in and out during quiet breathing. This is involving special muscles for contraction of the thorax and abdomen. This would be things like your internal intercostals, your external internal obliques, transversus, as well as rectus abdominis. This is going to move air very quickly out of the lungs because there's a higher pressure difference. More air is going to leave the lungs than in a regular exhalation. So let's look at this pulmonary ventilation process. So at rest, our diaphragm is nice and relaxed. Notice it just kind of forms that nice little rainbow almost underneath the base of our lungs. This is when our alveolar pressure is equal to atmospheric pressure, so there's no airflow. Then we get contraction of the diaphragm. When the diaphragm contracts, it flattens. Our rib cage is going to elevate, so ultimately this entire volume is going to increase. That's going to decrease the pressure, and that's going to force air into the lungs. Then you have exhalation, which is where your diaphragm relaxes. As your diaphragm relaxes, it's going to decrease the volume in the lungs, which is going to increase the pressure in the lungs, which is when that air is now going to escape to the atmosphere. Let's look at some of the muscles involved in this case. You have your internal intercostals for forced exhalation, external obliques, abdominal muscles. This is all for forced exhalation. On this side, again, we're just looking at the other side of the rib cage, the sternocleidomastoid muscles. These are for deep inhalations, really elevating that rib cage, getting your lungs to expand, getting your thoracic cavity to expand. Scalenes are going to help with those deep inhalations. External intercostals are going to contract during normal breathing, as well as the diaphragm muscle, which you can see here just in this red line that's marking where the diaphragm would be. Notice the asymmetry of the diaphragm. It kind of goes up higher on the right side than it does on the left, and that's again because that left lung has the cardiac notch taken out of it. So let's talk about pulmonary ventilation. This is the pressure differences creating are very, very small, only about 2 millimeters of mercury. And we can look back at this diagram here and you can see that. So here the alveolar pressure is equal to atmospheric pressure, which is 716 millimeters of mercury. Then as we're inhaling, our alveolar pressure is only 758 millimeters of mercury. So only 2 millimeters of mercury difference. Same thing here, 2 millimeters of mercury difference, which again is not going to make the air move very, very quickly because it's not that big of a pressure gradient. Ventilation is going to move roughly 500 milliliters or half a liter of air each cycle. The greater the pressure gradient, the more air is removed. So the quicker and faster your intercostals and rectus contract, the quicker the air is going to move in or out. Something called a pneumothorax is when you have a air introduced into the pleural space. So a lung collapse could occur in this space. Normally, the pleural space pressure is lower than within the lungs. So the pressure gradient and stickiness of the pleural fluid helps to keep the lungs nice and adhered and will enable them to move as a unit. However, a pneumothorax is when the air is introduced into that pleural space. The thoracic wall lung unit is then disrupted, so the lungs aren't sticking to that wall as they should. So this could cause an increase of pressure within that pleural space and the lung could collapse. A pleural effusion is when fluid collects in that pleural space. When either of those events occur, the lungs cannot inflate and ventilation cannot occur. Let's talk about various volumes of air. So we'll start with tidal volume. This is the volume of air that moves in and out during a normal breath at rest. Unless you're exercising as you're listening to this lecture, you're probably sitting at your computer reading along and taking notes. More than likely, you're unaware of your breathing at this time, other than the fact that I just mentioned it to you. The amount of air coming into and out of your lungs at this point is called your tidal volume. A healthy adult is going to breathe about 12 times per minute. Again, on average, it's about half a liter of volume that's exchanged. The majority of it is actually reaching the alveoli for gas exchange. The remainder, about 30% of it, is remaining in what we call the anatomic dead space. This would be the conducting passages of your nose, pharynx, larynx, bronchi, and bronchioles, which don't have an exchange surface. There's other lung volumes that you should be familiar with. One's called the inspiratory reserve volume, And this, you know, when you take a deep breath, this is the difference of air that you bring in over your normal tidal volume, as opposed to your expiratory reserve volume, which is the volume expelled over a tidal volume. So after you exhale normally, then try to squeeze the rest of the air out. That's your expiratory reserve volume. You'll get a chance, or at least you should get a chance in lab, to measure your expiratory reserve volume. There's also something that's called a residual volume. This is a volume of air that remains within the conducting zone of your airways, and it's not expelled unless the wind is knocked out of you, so to speak, or until death. And in some cases, in death, it even remains in there. Some of you may get a chance to visit what's called the Anatomic Gifts Registry with me this semester or next semester, and it's a really cool place where you get to examine a donated cadaver, and one of the coolest things that most students enjoy is feeling the residual air in the lungs of the cadaver. It kind of feels like Rice Krispies. Their lungs still have that residual volume in it. It's kind of a cool thing. So these lung capacities are basically combinations of specific lung volumes. So it's the percentage of air that the lungs can hold at a given period of time. It's smaller in older adults, smaller in females, and smaller in shorter people. Again, that all makes sense. The smaller you are, the smaller your lungs are, right? Something called the vital capacity is the volume of air moved from maximum inhalation to maximum exhalation. Your total lung capacity is your vital capacity and your residual volume. So for males, again, it's going to be larger, about 6,000 milliliters. Females, about 4,200 milliliters. Again, that's an average. A spirometer is the device that you may get to use in lab. This is going to measure your lung volumes and your lung capacities. A spirogram is a recorded piece of paper that is produced by that spirometer. When you do this in lab, you won't get a spirogram because ours are not electronic, but you will get a little reading on the gauge. A vital capacity measurement is important because it's going to give insight onto the lung capacity, lung flexibility, levels of airflow to the alveoli. Something like obstructive lung disease patients, they're going to have normal or higher lung capacities, but they may exhibit lower than normal airflow. Here you can see the spirogram and the various lung volumes. So your tidal volume during quiet breathing, about 500 milliliters. Then the patient is asked to exhale even more, right, pushing all of that air out after a quiet breath. That's the expiratory reserve volume. Then they're asked to take a deep breath, really, really inhale. That's a deep breath inhalation. That's your inspiratory reserve volume. Then you can resume your quiet breathing. The vital capacity is the difference between the expiratory and inspiratory reserve volume. The residual volume, notice that's down here. On average, it's about 1,200 milliliters. That's the volume of the air that's going to remain even after forced exhalation or your expiratory reserve volume. That, along with your vital capacity, gives you your total lung capacity of around 6,000 if you're a male, 4,200 if you're a female. So, changes in lung capacities and lung volumes could be useful in diagnosing things like asthma, COPD, emphysema, bronchitis, pulmonary fibrosis, sarcoidosis, pulmonary edema, etc. There are differences in breathing patterns. Eupnea, this is the normal quiet breathing, shallow, deep, combined shallow and deep breathing. That's what most of us are doing right now. Coastal breathing or chest breathing, this is shallow breathing with more of an upward and downward movement of the chest because of external intercostal contractions. If you've ever watched a newborn breathe, a lot of what they do is coastal breathing. Diaphragmatic breathing is abdominal breathing. This is deep breathing involving outward movements of the abdomen from diaphragm contractions. There's also breathing pattern disorders. Apneas are the absence of breathing. Premature infants with incomplete respiratory centers can have apnea. Heavy snorers can suffer from sleep apnea. This is when they periodically stop breathing. Breathing then reignites when the carbon dioxide levels build up to stimulate breathing again. So basically they're suffocating, and then their brain kind of kickstarts the pons to get those respiratory rhythms going again. Severe hypothermia can also induce absence of breathing. Head trauma patients can also suffer apnea. Dyspnea, this is difficult breathing because of airway obstruction. Foreign bodies, asthma attack could cause this. The lungs could also just be less flexible because of excess fluid or thoracic injuries. Various modified movements include coughing because there's a foreign body in the larynx or epiglottis. Sneezing can be caused by an irritation of the nasal mucosa. Hiccuping, irritation of the GI tract. Yawning is fatigue or someone else is yawning, which the precise cause of that is really unknown. Sighing is very emotional. Sobbing is emotional. Crying is emotional. Laughing is also emotional. But all of those can impair your respiratory movements. We'll stop here for part 1.